Yeah, I'm here straddling the whole of the patient pathway from diagnostics through imaging, through diagnostic biopsies to intervention, to treat cancer, but also to radiotherapy. And I just want to talk a bit about the impact on all of that, and also what innovations we'd really like to see kept going forward. I mean, I think all of us who work in the health service have realised that with the step down of elective treatment, although that has been a major problem in the future, will be a major problem in the future, we've actually now got the diagnostic imaging service that we want. There are no backlogs. The patient has a CT scan, the CT scan report is there and then. We can get patients discharged from ED, we can facilitate discharge from medical wards. GPs are not getting as many phone calls from the patients while the patients suffer from that new word that somebody told me, scanxiety, while people wait for the result of their tests. And I think we need to hold on to this, the way imaging should be as we move forward. As Neil mentioned, there was a great deal of problem with surgery during the initial phase of the pandemic, and our interventional radiology colleagues were able to take on some of that burden, not all of it, but some of it. They assisted with line placement and drainages in ITU, but they also did some minimally invasive techniques, some ablative cancer therapies, which continued because they did not need the full surgical intervention. And I think that's a bit about those boundaries that we have between doctors and between specialties. They are not necessarily as strong as they once were. And in terms of clinical oncology, we kept going during the pandemic. We managed most of the treatments we kept going with. We also managed to absorb some patients who were transferred from surgical services, especially head and neck patients, or for small lung cancers where patients were very concerned about the risk of postoperative COVID. We were able to treat those with curative intent with stereotactic ablative radiotherapy, one of the new radiotherapy techniques. So I think there have been positives in COVID, and I think it is something about, as Peter said, it's about capturing those positives and banking them and moving forward and building on them for the future to keep the service that we want to see. I think for diagnostic radiology, we are well aware that the estate footprint for most radiology departments is small, and about 30 trusts in England only have one CT scanner, so the cold and hot site and the cold and hot areas are not ideal. So we would like to expand capacity, keep initially the independent sector capacity we've had, but also to move into a new model of community diagnostic hubs where patients can go to a COVID-light area and where patients, as you say, feel safe to go and have their diagnostic test. This increases the capacity, it also increases the throughput we can do, and it also supports the re-ramp up of diagnostic services. For oncology, we are very keen to continue the rollout of the technical radiotherapy. Peter alluded to the SABRE rollout, which we are very keen to support. But what this needs is IT connectivity, a large networking solution between all of the departments, so we can share images easily, share expertise, allow for peer review of radiotherapy planning, which is a huge quality improvement issue, but also it allows us to deal with patient staff absences, maternity leave in a workforce that's very stretched. And I think whilst we do want to look at new pathways, we want to look at decision support software to allow us to get the right test to the right person, I think we do also have to talk a bit about workforce, new ways of working, but also expanding the workforce as we go forward. Thanks.
Jeanette, thank you very much indeed. Extremely helpful and very comprehensive. I'm most grateful.